For this session, we will be discussing all about lens, the anatomy and physiology of the lens, the formation of cataract, the entire process of it. Okay, so what is basically the lens? The lens is a crystalline structure. It is transparent, it is avascular. Those are the important features of the lens. Now, the lens is seen in the anterior segment of the eye. The anterior segment of the eye consists of your cornea, your iris, and your lens. Now, the lens is suspended by zonules. Okay, these are the zonules which are suspending the lens on all around 360 degrees. Okay, now these zonules are attached to the ciliary body all around. Okay, now this ciliary body, when the ciliary muscle inside here contracts or relaxes, that changes the shape of the zonules, which in turn changes the shape of the capsular bag inside which the lens is being held. Okay, now it is enclosed by this capsule, which I already mentioned, which has an anterior capsule and a posterior capsule. Both the anterior and the posterior capsule come and join in the equator region, and from here the zonule attachment starts. Okay. Now, the diameter of the lens, the entire diameter is about 9 to 10 millimeters in size. The thickness of the lens can change with age. At birth, it is about 3.5 millimeters, and towards the extreme of age, that is in older people, it goes up to about 5 millimeters in size. Okay, so from 3.5, it goes up to 5 millimeters. All right. The total weight is about 135 grams. But as the person keeps growing older, more and more cells keep getting accumulated in the lens. The weight can go up to about 250 till 300 grams. Okay. The radius of curvature, the anterior surface is about 10 millimeters. For the posterior surface of the lens is about 6 millimeters. Now, the anterior and posterior surface, like I had mentioned to you, both come and join at the equator region. Okay. The refractive index of the lens is about 1.39, and the total refractive power of the lens is about plus 15 or 16 diopters. Now, if you see the lens here, anteriorly it is bound by the iris. The iris comes, the pupillary part of the iris comes and rests on the lens. Okay, it's not necessary that it touches it all the time, but there are points where it comes and rests on the anterior surface of the lens. The posterior surface of the lens is in contact with the vitreous. Okay, the anterior hyaloid phase of the vitreous. And it is also attached here, if you see the attachments to the ciliary body via the zonules. Okay. Now, the structure of the lens as such, it is bound by the capsular bag. Inside the capsular bag, in the center, you have the nucleus. Okay. The center part of the nucleus will be the oldest cells. So, the embryonic cells will be in the most center portion of your nucleus, followed by your fetal cells, infantile cells, and so forth. As the child grows, with every period of growth, there will be a ring which will keep forming around this. Okay. As the rings keep forming, with the age, the cells keep getting compacted, and the nucleus becomes like a tight and a hard part. Okay. Now, the nucleus is surrounded by the cortex, which is little loose. Again, the cortex is all made up from the anterior epithelial cells. New fibers of the lens are continuously laid down from childhood till the person is alive. Okay, it is an ongoing process. Now, these are all getting, the capsule is responsible for the molding of the shape of the lens. Okay. Now, in the capsule itself, the thickest portion is in the equatorial zone, and the thinnest part is the posterior pole of the lens. Okay, so in the back portion of the lens, in the peripheries, you have the equator region. Okay, and here the capsule is thick. But in the center portion, which is the pole, okay, the posterior pole, here the capsule is not thick. Okay, so because of this, in the center portion, there is a slight bulging of the lens which is seen. Okay, this is what is responsible for the conoid shape of the lens in the posterior part. It's not really a smooth structure, but it is smooth here, and in the center, it comes as a conoid structure. Okay. Now, a single layer of epithelium lines the equator and the anterior lens capsule. What is important is that it is only present in the anterior part. This is not present in the posterior part. Okay. From here, it comes up to the equator, and at the equator, it bows in. Okay. This is what gives rise to the continuous repeated laying of the layers of the nucleus and in the cortex of the lens. Okay, that is important. Only anterior epithelial cells are present. No posterior epithelial cells are present in the lens. Okay, now these, when in the equator region, they show a very high mitotic activity. They lose off all their organelles and they become elongated. They are stretched. Because of this, this is an important feature for the transparency of the cells in the lens. Why? Because there are no organelles, the cells are stretched out. Because of this, there is transparency in the lens cells. This is what I was talking about. This epithelial cells bow inside, coming into the structure of the lens, and this is what is responsible for this pattern formation of the lens cells deposition. Okay. Now, coming on to the factors which are responsible for the lens transparency. First, most important thing is the avascularity of the lens structure by itself. Okay. Then, the lens cells are very, very tightly packed. As the lens cells keep growing and growing, they are compacted more and more towards the center. This tight packing does not allow anything else to get in between, and the transparency is maintained. In addition to this, the lens protein are arranged in such a way that they keep the hydration or the fluid out of the lens. That is mainly because of the protein structure. In addition to that, the semi-permeable character of the lens helps in the pump mechanism. Now, this pump mechanism, the sodium-potassium pump, okay, which is present and happening at the anterior capsule of your lens. Now, the lens is deriving most of its nutrients from the aqueous humor, which is in front of it, in the anterior chamber. Okay. Now, because of the semi-permeability of this anterior capsule and because of this pump mechanism, there is an active exchange of ions and energy and requirements which are happening across this semi-permeable membrane. Okay. This pump mechanism is very important for the lens because it maintains the lens in a state of a relative dehydration. Okay, so it keeps most of the water out of the lens. So because the lens is kept in a dehydrated state, the transparency is maintained. In diseases such as diabetes and all, what is happening is lot of glucose is inside the lens. It is pulling a lot of fluid inside the lens. Hydration of the lens happens, so clouding of the vision happens. Okay, so anytime the sugar goes up, you will see that the refractive error of a person changes. This is because of increased amount of hydration of the lens. Okay. Now, there is also auto-oxidation and a high concentration of reduced glutathione which is present in the lens. This again is responsible for keeping the lens in its dehydrated state. Okay, and responsible for the generation of the energy that is required by this sodium-potassium pump mechanism. Now this is basically what is happening across the anterior capsule. So this is your anterior capsule here. The water is kept at a balance. The aqueous humor has got more amount of water content. Inside the lens, the lens is kept in a dehydrated state. Okay. Now because of the sodium potassium pump, okay, the sodium is kept out of the lens. If you see, the amount of sodium outside is much more as compared to inside of the lens. But the amount of potassium is high inside the lens as compared to the aqueous humor. Similarly, the amount of glutathione and the amount of inositol and the amino acids, proteins, all these things are higher inside the lens as compared to outside of the lens. Coming on to the diseases of the lens with the cataract. Okay, now what is cataract? Cataract can be any congenital or acquired opacity in the lens capsule or the substance of the lens. Okay, irrespective of the effect of vision. Okay, now these can be small opacities which can be seen, which do not disturb the vision, or can be large opacities in the center of the vision pathway, causing a disturbance in the vision of the patient. Now, the classification of cataract can be done in two ways. We can do the morphological classification or the etiological classification. In morphology, basically where is the cataract situated? According to that, we will divide it. So, it can be in the capsular region. It can be in the anterior capsule or in the posterior capsule. It can be subcapsular, again, just under the capsule. So, it can be again anterior subcapsular or posterior subcapsular. It can be in the polar regions. Now, here it could be either in the anterior polar region, the posterior polar region, or bipolar regions. Okay, both the poles are involved. Then the cortical cataract can be there, which involves the cortical matter which is around the nucleus. In the supranuclear, just in the cortex, but just above, in between the cortex and the nucleus, is the supranuclear area. Then you have the nuclear type of cataract, which is in the center or in the nucleus of the lens. Then you have the sutural. The sutural cataracts are seen along the sutures where the lens formation has happened and the remaining suture line is seen. In the anterior capsule, it is a straight Y pattern, and in the posterior capsule, it is an inverted Y pattern. Now coming on to etiological classification of cataracts. It can be divided into congenital, which is since birth, or developmental, as the child is growing and there is some problem, some kind of infection, some kind of malnutrition or some disease process because of which he has developed a cataract. Okay, it could be age related or senile cataract. As the person keeps aging, the cells keep getting packed and packed and packed. After some time, the nucleus becomes very, very hard, jam-packed with cells. Okay, and the nucleus becomes very thick. This thickness results in an opacity formation. It becomes opaque. So, you will have a age-related or a senile cataract. It could be because of trauma. It could be because of some secondary pathology in the eye or in the systemic thing. Any complication from there, if the person develops a cataract because of that, it is called a complicated cataract. It could be secondary to diabetes, secondary to some kind of toxic reaction or a drug-induced cataract. It could be radiational cataract or secondary to any dermatological diseases. Okay. Now, what kind of a damage is actually happening because of the processes? What is the process by which the cataract is getting formed? So, in increasing age, what is happening? There is continuous oxidative damage. You must have heard of this word a lot of time. Oxidative damage. Yes, that is responsible for cataract formation because it is denaturing the proteins inside the lens. Okay. In sunlight, what is happening because of high exposure to sunlight, there is a damage to the protein which leads to hydration of the lens. Because the protein got damaged, fluid gets accumulated in these pockets. Hydration of the lens. Okay. In severe diarrheal dehydration, there is denaturation of the proteins, again hydration and cataract formation. Because of vitamin A, C and E deficiency, there is a fibrous metaplasia which is happening. There is opacification of the lens fibers by itself. Okay. In diabetes, there is again opacification of the lens epithelium. In addition to this, what happens is when the glucose amount inside the lens increases and hydration of the lens is also happening. Fluid gets pulled inside the lens, vacuoles get formed. Around these vacuoles, collection keep happening. Okay. Because of smoking, there is accumulation of pigment molecules within the lens. So it's a very gradual process. This itself, by itself, is not going to cause a very visually significant cataract. Okay. In corticosteroids, again, the osmotic balance of the lens pump mechanism gets totally deranged. Okay. So the lens starts getting hydrated again. Again, swelling up of the lens and opacification of the lens fibers happens. Genetically, if there is a failure of the ion pumps, dehydrated state of the lens is not maintained. Thus, cataract formation. Now, coming on to the mechanism of the loss of transparency in the lens. So, whenever there is an increased amount of sodium inside the lens, a decreased amount of potassium is inside the lens, or there is a decreased amount of protein or amino acids inside the lens. Okay. This is responsible for the overhydration of the lens. Okay. This leads to coagulation of the proteins and a cataract formation. Coming on to what different types of cataracts are there. First one we'll be dealing with is a nuclear cataract. Now here what happens is it could be because of age-related changes, like I had explained, because of the packing of the lens cells which is happening over the years. Okay, because of this, it is intensification of the age-related nuclear sclerosis, because it is associated with a dehydration and the compaction of the nucleus. Okay, because of this entire process, there can be an increase in the formation of the cataract more than the normal. Okay, here it may not be associated or may be associated with pigment deposition. The pigment can be a urochrome or a melanin pigment from the amino acids. If you see in the picture, a nuclear type of cataract is only seen in the center portion. So here the pupil has been dilated. As you can see, the outer part of the lens is absolutely clear. The cortex is absolutely clear. Only the central nuclear portion of the lens is getting involved in cataract formation. But with nuclear cataracts, the cataracts are visually significant because they are in the center of the pupillary area and they affect the visual pathway. Now, coming on to the types of senile cataract. Okay. Now, you have the stage of lamellar separation. Here, what is happening? There is a demarcation of the cortical fibers which is happening because of the fluid which is getting inside the lens. Once the fluid gets in, there is an area which is created. Okay. Now, this is one of the earliest change which is happening. An important thing is it is reversible. If at this point, the person takes some precaution, because all these changes, if it is happening because of a disease process or because of any other thing, and that process is stopped, all these changes will be reversed and cataract formation is avoided. Okay. This was lamellar separation. Okay. The second one is stage of incipient cataract. Okay. These in between, in the clear areas, you see opacities. Okay. Now you have the separation happened. Now there are areas where there is clearing and there are areas where there are opacities seen. Okay. So these are one of the earliest changes that can be detected when we are looking at the patient through a slit lamp. There are two different types. You have the cuneiform cataract and the cupulliform cataract. I will explain to you. The cuneiform cataracts are basically wedge-shaped opacities, or they are in the form of riders, okay, spokes. So if you have your nucleus, if you have your lens like this, they appear as wedges like this, or they appear as lines like this, okay. These are your how your opacities appear in the cuneiform cataract, okay. Now, on oblique illumination, when you see, they have this typical spoke-like pattern with grayish opacities coming into the capsule of the lens, okay. Then, if you see on distant direct ophthalmoscopy, you will find a red color glow because of the retina. On the red color glow, these things will appear as black lines or black wedges in the red glow, okay. That is a cuneiform type of cataract. Now, coming on to the cupulliform type of senile cataracts. Here what happens is, the changes that you see are characteristically posterior subcapsular, okay. They are in the subcapsular region on the posterior part. But here, important thing is they start in the center and they grow outwards, okay. As compared to the cuneiform, which grows from outwards and comes towards the center, the cupulliform are more visually significant at an early stage because they start from the center and grow outwards, okay. There will be a definite demarcation line which will be seen between the cataract and the clear portion of your lens. Because it is in the center of the visual axis, early loss of visual acuity and early requirement for a cataract surgery will be seen in patients with a cupulliform kind of a cataract. Coming on to the immature senile cataract, here what happens is, as the cataract process keeps growing on, there will be opacification which becomes more and more diffuse and it becomes irregular. The lens starts, instead of being clear, the lens starts becoming grayish white in color, okay. The lens changes its color. The clear cortex is still present, okay. If the clear cortex is still present, a phenomena known as the iris shadow can still be appreciated. What is iris shadow? If when you are examining the patient, if you shine the torchlight or the light source from the side of the patient, okay, when you shine it from the side, because the iris is in front and the lens is behind the iris, there will be an area on the lens where you will see a shadow forming because of this iris which is anterior to it. So like there will be a crescent pattern of blackish area which will be seen on the lens. But this is possible only if there is still clear cortex which is present. Okay, if the entire lens has become opacified, iris shadow cannot be appreciated. Okay. Now, at this stage, what happens is the lens can become swollen up. If it becomes swollen up, what happens is there is fluid accumulation. There are vacuoles formed in which there is fluid. Okay, because of this, hydration of the lens is happening. Lens is getting swollen up. This is called an intumescent cataract. Intumescent cataract. Because of this and intumescent cataract, two things can happen. The lens is swollen up, the lens starts coming anterior and touches the iris. Okay, iris shadow becomes absent because now the lens and the iris are in the same plane. It is not behind anymore. It has come to the same plane because it is swollen up. The second thing that can happen is the anterior chamber of the eye starts appearing to be shallow because the lens is pushing the iris and itself it is coming in the front. So the anterior chamber of the eye becomes shallow. Coming on to the mature cataract, Here what happens is the entire, in addition to the entire nucleus, the cortex also becomes opacified. Because of the opacification of the cortex, the lens becomes pearly white in color. So the cortex, which was loosely arranged, once that opacification becomes complete, it becomes very fluffy and white in color. Okay. After maturation of the cataract, it can go into a state of hypermature cataract. Now this can happen in two forms. The first of it is called the Morganian cataract. Okay. As the maturation of the cataract keeps happening, the whole cortex, once it has become this fluffy white opacification, it keeps becoming more and more mature and it starts to liquefy. Okay, till the entire capsular bag, entire cortex becomes liquefied. It becomes like a bag of milky fluid. Okay, and in the center, which the nucleus which you had, the hard part of the nucleus sinks down. So when the patient is standing up or is sitting down, the nucleus sinks down in this bag of fluid because there's nothing to hold the nucleus up. Okay, and when the person turns either side, the nucleus slowly moves to that side. Okay. Now the small brownish nucleus, I told you, usually settles at the bottom when the patient is standing up. In this picture, if you see, this is your clear part of your eye. If you see here, this is your hard nucleus part and this is the portion where the bag is clearly seen. Okay. At this stage, there might be some calcium deposits which can be seen in the cataract. Not necessary. Older patients, it's very common for the calcium deposits to be seen. The other type of hypermature cataract is called the sclerotic type. Now here what happens is, with the maturation of the cataract which is happening, the cortex starts disintegrating and the lens becomes shrunken. Okay, now the fluid that was there has seeped out. Okay, the fluid seeps out, the lens becomes shrunken. Instead of being swollen up, now the lens has become shrunk. Okay, here what happens is the anterior capsule and the posterior capsule start showing wrinkling. Because of this, the volume has become less. Now the bag doesn't know what to do, so it's shrink or it becomes wrinkled up. Okay, and here it will also start becoming thick because of the proliferation of the anterior cells, anterior epithelial cells, which is still going on. Okay, anterior epithelial cells will start showing changes. So here if you see, this is your entire bag. The lens is, the opacification that you can see is only in this area. Here you can see some clearing, but there are some dots and opacification which is still seen. This is a characteristic sclerotic type of a hypermature cataract. Now, how is the sclerotic process happening? The sclerotic process usually starts in the center. And from here, it slowly keeps spreading out towards the periphery. Okay. So, initially what might happen, there may be a peripheral zone which is not affected or it is still clear. But slowly, as the process keeps happening, as the maturation keeps happening, the sclerosis spreads to the periphery as well. Okay. Now, in the nucleus itself, there will be a lot of change in the color which is happening of the nucleus because of this deposition of the cells which is continuously happening. So, initially, we call it the cataracta brunescens when the nucleus shows a amber or a brown color. Slowly, with more and more maturation, it turns into a cataracta rubra, which is reddish in color. Finally, coming on to cataracta nigra, which is black in color. Okay. Now, as the color keeps increasing in darkness, so does the hardness of the lens also increase. Okay. So, when the lens is clear, slightly grayish, slightly yellowish or early stages of brown, you can still do a surgery very comfortably where the nucleus can be broken into pieces. But as the grade keeps becoming dark red or black or dark brown, the cataract nucleuses become hard like stone. Okay, so cutting it with the phaco probe when you're doing a phacoemulsification surgery keeps getting tough and tough because more amount of energy will be required to cut through this hard stone like cataract. Okay. Now, what are the symptoms that the patient will present with? Once the cataract starts forming, the patient can undergo many small changes. It's a very gradual process. That is important to know. So suddenly the patient is not going to start having complaints. It is a very slow process which is happening over the years, and because it is so slow, lots of patients do not realize till it becomes significant for them to go to a ophthalmologist. Okay. Most common thing that the patient will complain of is a blurring of vision. At later stages, this can become into a loss of vision. Now, usually this presenting sign cannot be a loss of vision until and unless it is a acute episode which has happened. Okay. Now, if somebody got an injury or a trauma or something, then the person's lens can turn cataractous immediately, but not because of a normal senile cataract. Okay. But if one eye is affected and one eye is absolutely normal, patients can present with loss of vision. So, for example, while taking a photograph in the olden days and all, when they used to close one eye to look through the camera, or while trying to do some shooting and they are looking through a small target, when they close either of the eye, suddenly the realization dawns on them that they are not able to see clearly from one eye. Okay, in those cases, the patient can come directly with a complaint of loss of vision in one eye. Okay. Then, if the patient has come at very late stage, in addition to this loss of vision or decrease in vision, the patient might himself come and tell you that I have this white thing in my eye. I have noticed this white thing in my eye, which is cosmetically disturbing them. Okay. Not very common nowadays because people have become more and more aware of cataract and what it is, how it is, all those things. Okay. Now, many people will come to you with history of frequent change in glasses. Now, as the cataract is maturing inside the lens, as the lens itself is undergoing lots of changes because of hydration, because of change in the protein, and because of the denaturation of the protein or whatever, there will be lots of stages when the lens might become intumescent, a little swollen up. It will become less because the dehydration of the lens is happening. So the patient will come to you saying, I recently got these glasses changed and now I am unable to see clearly with this new glasses. That is because the refractive error keeps going up and down. Okay. Because of the hydration of the lens, the refraction keeps changing repeatedly. This is commonly seen in diabetic patients with the up and down in their sugar levels. Even during the day, the lens can swell up or decrease in size depending on the sugar values. Okay. Patient can complain of uniocular polyopia. Okay, doubling and trebling of objects can be seen, or the thing is not appearing to be clear because they are seeing multiple images of that. Okay, side to side. This could be because of the fluid vacuoles which are there inside the lens affecting the vision. Because of this, because of the edge of the fluid vacuole, when the patient is looking through that, there will be doubling. And if he is looking through 2 or 3 bubbles at the same time, because of that, the vision keeps getting changed. Okay, because the light is going through multiple media at the same time. Colored halos, again, will be seen because of the hydration or the fluid vacuoles inside the lens. So, because of this, when the light is falling on the fluid portion, it is breaking up into a rainbow pattern and the person is seeing colored halos. Glare is basically when they go out in the sunlight, they are unable to look at the bright objects or go out in the sunlight. what happens is, because of the light falling onto these areas where there are spaces inside the lens or there are fluid vacuoles inside the lens, the light is splitting up and it is becoming too bright for them to see anything. Okay, so that is called photophobia or a glare. Now, symptom-wise, depending on whether the patient has a cuneiform, which is a central type of a cataract, the vision here will be affected early, okay? But in the evening time or in the night time, the vision will be slightly better, because in dim light situation, when the pupil becomes a little larger, mydriasis occurs, more and more light is falling from the sides. The vision is better in the evening time, okay? So these patients will complain of day blindness, that during the daytime or when they go out in the sunlight, they are unable to see anything. But once they come inside the room or they are in an evening situation, the vision becomes better. As compared to a cuneiform or a peripheral cataract, where the vision initially is not affected because the cataract opacities are mainly towards the periphery of the lens, okay? Here, the vision becomes, patient has complained that in the evening time, the vision becomes worse because pupils are dilating, but the light which is coming through is getting obstructed because of these peripheral opacity. Now, symptom-wise, in nuclear sclerosis, what do we see? That the distance vision, okay, nuclear sclerosis is what? In the center part, in the nucleus part of the lens, there is sclerosis, so there is slight thickening, okay. Now, because of this, what has happened? The lens in the center portion has become slightly thicker, okay. So, the patient's distance vision might reduce, but the near vision of such a patient improves, okay. The lens has become thickened, accommodation is happening. Something similar to accommodation process is happening. So the reading becomes better. Okay. This is also known as a second sight. This process is also referred to as a process of second sight. So when the cataract is developing and the patient is developing a nuclear sclerosis, they will come and say, my distance vision has become very bad. But somehow now, earlier I used to require glasses for reading, but now I don't need glasses for reading. Okay. Second sight. Now coming on to the signs of cataract. Okay. So first and foremost, when the patient itself is complaining to you, there will be a decrease in vision. So when you chart the type of vision that they have, they could be, because depending on the type of cataract that they have, they would be able to read the Snellen's chart. They might not be able to read the Snellen's chart depending upon the type of cataract that they have. So there will be a significant decrease in the visual acuity. Iris shadow, like I had explained, if it is an immature cataract, you will see the presence of an iris shadow. Immature cataract also, if there is no intumescent cataract which is seen at that stage. That is, if there is no swelling up of the cataract which is happening, an iris shadow will be present. Okay. On oblique illumination, what all can you see? You will be able to see the color of the lens. Okay. Now, in the color of the lens, if it is an immature cataract, you may see it as a grayish white opacity. If it is a mature cataract, it will be milky white or white, pearly white. Okay. As the cataract mature, it becomes hypermature. It will start becoming brownish in color or so. In the stages of nuclear sclerosis, you will see initially a little thickening which will appear as a yellowish coloration of the nucleus. Okay. As the grades keep increasing, as the thickening keeps increasing, it will become a amber color, slightly brownish in color, reddish in color, or black in color. Okay, those are the grades of the nucleus as such. Now, on distant direct ophthalmoscopy, you will see a red glow from the retina. On top of the red glow, you will see the cataract appearing as black spots or black lines, depending on what stage of the cataract it is. Again, if the cataract has become a mature cataract or it is a hypermature cataract, there may be a total absence of the red glow. because the light is not reaching the retina, a reflection from the retina is not happening. So in those cases, a distant direct ophthalmoscopy will not be possible. On a detailed slit lamp examination under dilated pupil examination. So you have to dilate the person's pupil and examine afterwards also. You will examine before and you will examine after dilatation. Okay. Now in this, what happens? You will be able to see the edge of the lens clearly, and you will also be able to see if there is any slight zonule damage, because of which there might be a subluxation, mild dislocation. If there is any other pockets where there is damage to either the anterior or posterior capsule which is there, if there is anything else noteworthy, you will be able to note in your slit lamp examination. Ideally speaking, a fundus examination also has to be done, which is important in cases where there is a systemic illness which could affect the fundus, like diabetes and hypertension. You also need to see for the changes which are there because of the disease process by itself. Now, suppose the cataract has not been operated. What can happen? Suppose the patient says, no, I don't want to remove the cataract. It's okay. What will happen? There are complications which can occur if you leave the cataract there itself. Okay. One of them is a phacoanaphylactic uveitis. Now, here what is happening in a hypermature cataract? Okay. The lens proteins which are there are leaking into the anterior chamber of the eye. Okay, because of this, proteins which are not supposed to be there are there now. The body produces an antigen antibody reaction in the anterior chamber, which results in the formation of a uveitis. Okay, a full-blown uveitis can be seen in a hypermature cataract which has not been treated. Second thing that can happen is a lens-induced glaucoma. Now, this can happen in two ways. One is called the phacomorphic glaucoma and the other one is called the phacolytic glaucoma. Okay. Now, in the phacomorphic glaucoma, it is seen usually in the cases where there is an intumescent cataract. This is like a mechanical obstruction which is happening. The lens has swollen up. It is pushing against the iris. Now, as you know that the ciliary body which is at the back next to the lens is producing the fluid. Okay, the aqueous humor is getting produced there. From here, the aqueous humor is coming into the posterior chamber. Then around the pupil, it is entering into the anterior chamber. Now, the lens, because of its intumescent nature, is sitting right in proximity to the iris. Okay, so it is blocking the pathway from which this fluid, the aqueous fluid, can flow from the posterior chamber into the anterior chamber. So there is a buildup of the aqueous fluid behind the iris which is happening. As this buildup is going on happening, the drainage of the fluid is not happening, but the buildup is continuously going on. This will result in a glaucoma, a phacomorphic type of a glaucoma. In cases of hypermature cataract, where the protein leakage is happening, this protein which is coming to the anterior chamber can go and block the trabecular meshwork, from where your normal aqueous was getting drained out. Because these proteins are larger in size, they go and block the trabecular meshwork. Now, the amount of aqueous which is producing is normal, but the amount of drainage has decreased. It is not getting drained. Collection starts building up, okay, results in a phacolytic type of glaucoma. The third thing that can happen is in a cataract which is there. Now, what has happened? Because cataract formation has happened, there is all these changes which have happened. Now, the cataract by itself is a little heavy as compared to a normal lens, okay, because of all the changes in it, okay. Now, in addition to this, there is constant toxins which are getting produced, okay. And with aging, as it is, the zonules are becoming weak. If the zonules keep becoming weak, there may be subluxation or dislocation of a lens which can happen if the zonules break, okay. So, these are all the complications that can be seen in a cataract which is not being treated. coming on to some special cataract categories, okay, where you see these specific characteristic kind of cataracts, okay. First is a diabetic cataract. Now, what happens in a diabetic cataract, you get this characteristic thing called the snowflake or the snowstorm cataracts. These are usually seen in young adults with diabetes, okay. Now, what is happening is because of increased amount of glucose in the lens, fluid is getting pulled into the lens. There is an osmotic overhydration of the lens which is happening. Now, around these multiple vacuoles of fluid which are in the lens, there will be opacification which will be seen around these vacuoles. So, vacuoles got formed, around it opacification happened. It will look like a snowflake cataract or a sorbitol cataract, okay. The second one is a galactosaemic cataract. Here, basically, if you see here, you will see a clear outline here. It looks like an oil droplet, okay, and it is seen in the center of the lens. So, it will be an oil droplet, central lens opacity which will be seen, okay. This is usually a reversible change, okay. If the galactosemia, what is producing the cataract is stopped, okay, then the person's changes will reverse. And these are bilateral changes which will be there. It may not be symmetrical, that is one side may show more change as compared to the other, but usually both the eyes are affected. And at this stage, if correction happens, the oil droplet goes back to its normal lens shape and structure. Coming on to cataract because of errors in the copper metabolism. Now, in Wilson's disease, okay, you see a sunflower type of a cataract, okay. A sunflower type of a cataract can be seen. This is a very rare finding. More common finding in a Wilson's disease will be a ring, which is seen around the cornea, which is known as the KF ring, the Kayser-Fleischer ring, okay. But in rare cases, you might also see a sunflower cataract. Now, the characteristic of this cataract is, in addition to the floral pattern that the cataract itself has, is that it is greenish in color because of the copper deposition, okay. Coming on to something known as a complicated cataract. Now, what happens is, if there is any disturbance in the ocular fluid circulation, or if there is any presence of an inflammatory toxin in the lens itself. Now, what happens is, this causes a distribution in the lens nutrition. So, the lens is deriving its nutrition from the anterior chamber. So, if there is any problem there will be a disturbance in the lens nutrition. Because of this, a cataract will form. This is known as a complicated cataract. Because of any other disease process, when there is a cataractous change which is seen in the lens, it is known as a complicated cataract. Coming on to the etiology of a complicated cataract. What all can cause a complicated cataract? Firstly, inflammatory conditions in the eye. Anywhere in the eye, if there is an inflammation like an iridocyclitis, a pars planitis, choroiditis or endophthalmitis. Any of these conditions where there is an inflammation in the eye, it can affect the nutrition of the lens, resulting in a cataract formation. Okay. In addition to this, degenerative conditions of the eye such as retinitis pigmentosa or a myopic chorioretinal degeneration, because of high myopia, when there is chorioretinal degeneration, all those can also lead to a complicated cataract formation. Now, complicated cataracts are also seen in retinal detachment, in primary or secondary types of glaucoma conditions that are there, and in cases where there are intraocular tumors such as retinoblastoma and melanoma. Now, any of these conditions can be responsible for the formation of a cataract. So, that will be called a complicated cataract. What is the appearance of this type of a complicated cataract? Usually, it is seen in the posterior cortical region. Now the appearance can be either a bread crumb kind of an appearance, where you see this crumbly kind of a pattern to the lens. That is called the bread crumb appearance. Or you can have a polychromatic luster. There will be these points which is giving a lot of luster. Now this luster can be associated with many colors. It could be red, green, golden, silver, any of these colors. Okay. So when you look at it through the slit lamp, in addition to that crumbly appearance of a bread, you may see these polychromatic luster granules. Okay. Which is very, very characteristic for a complicated cataract. Coming on to the radiation cataract. This is also known as the glass worker or a glass blower's cataract. This is because of increased exposure to the infrared rays. The people, when they are doing the glass blowing work, they have to stand very close to the furnace where they are going to pick up the glass liquid thing and blow it into a vase or a vessel or whatever. Okay, because of this proximity, they get a glass workers or a glass blowers cataract. Now, what is characteristic in this is you get these posterior subcapsular opacities. Okay, that is in the lens as such. But in the anterior capsule, if you see, this kind of a pattern which is seen is the true exfoliation of the anterior capsule will be seen. Now, this exfoliation pattern can be seen only when the patient's pupil is dilated fully. You will be able to appreciate it. Okay. Otherwise, you will only be able to see the subcapsular opacification. Okay. Coming on to the next type of cataract, which is known as an electric cataract. Usually, this kind of a cataract is a star-shaped cataract. Occurs after a person has received a very strong and powerful electric shock. As you can see here, it will affect both the eyes at the same time. The affection can be asymmetrical, but most of the times both the eyes are involved. Okay. Now here what is happening is it initially starts off as punctate subcapsular opacities. It is just under the capsule. You will find these small dot-like opacities which will be there in the beginning as soon as the person has got the shock. Okay. But these progress very, very rapidly. Okay. And require treatment at an early stage as compared to any other type of cataract. Cataracts associated with myotonic dystrophy. Here you see a Christmas tree cataract. Okay. Now, why do you get the cataract? Is because of an increased level of gamma glutamyl transpeptidase. Gamma glutamyl transpeptidase. Now, because of this, it causes a decrease in the level of glutathione in the lens. This leads to the cataract formation. So, what will you see? You will see these small multiple needle-like patterns which will be arranged, okay? And in between this, you will see small multicolored, deep-set polychromatic spots, okay? Now, these spokes look like the spokes of a Christmas tree, and these spots start appearing multicolored, so they can be blue, red, green, golden, any other color, okay? So, they look like the small lights on top of a Christmas tree. That is why it is called a Christmas tree pattern of a myotonic dystrophy cataract. Okay. Coming on to the summary of what all we have done in this session, we've discussed about the anatomy and the physiology of the lens. Okay. We've gone into what exactly is a cataract. How can you classify the cataract? You can classify it on morphology as well as on etiology. How is the cataract formed? From the beginning to the end, how is the maturation process of the cataract? Okay. What are the clinical features, the signs and symptoms that the person will walk into your clinic with? What are the complications that we can have because of a cataract? And we have discussed about characteristic types of cataracts that we see associated with certain disease processes. That's all for this session.